Hello, everyone. Welcome to the third episode of the international edition of The Art of Drug Choice, Wet AMD and the latest data. Again, it's my pleasure to have our esteemed faculty, Dr. Seenu Hariprasad from University of Chicago.
Thank you, Arshad, for the kind introduction.
Dr. Justus Garweg from University of Bern in Switzerland.
Happy to share the discussion.
And Dr. Peter Kertes from University of Toronto, Canada.
Thanks, Arshad. Happy to be here.
Welcome, everyone. So this episode is third of the fourth episode series that we have. Today, we'll review a few pipeline candidates for wet AMD. We'll also hear a case from Dr. Hariprasad today. If you want to hear a discussion on tactics for switching wet AMD patients to different drugs, or a discussion of the latest phase 3 and post-marketing data for wet AMD drugs, please go back and listen to our first two episodes. Next time, we'll discuss safety as it relates to the next generation of wet AMD drugs. Now, let's get into our review of pipeline candidates with Dr. Seenu Hariprasad telling us a little bit about KSI 301.
Thank you so much, Arshad. KSI 301 by Kodiak Sciences is a very interesting molecule. It's an antibody biopolymer conjugate, or it's called an ABC technology. The biopolymer is a branched polymer, is optically clear, and has a very high molecular weight, over 1 million Daltons. KSI 301 is designed for intravitreal delivery and allows for high potency. The phase 1b trial results are as follows. Patients received doses at weeks 0, 4, and 8, and were monitored to 18 months. At the end of 1 year, patients gained an average of 5.7 letters from baseline. 80% of patients needed less than 2 treatments in the first year. 54% of patients only needed 1 retreatment at the end of 12 months. And 66% of patients were at 6-month treatment intervals through the first year. But what's very important is to keep an eye out for the phase 2b/3 DAZZLE FDA registration study called DAZZLE. And it's a pivotal study for wet AMD. 550 patients or more treatment-naive patients with wet AMD will be fully enrolled in the study. And the results will be released at early in 2022, as the last 1-year visit will be late in 2021.
Thanks, Seenu, for an excellent summary. Of course, KSI 301 is designed to decrease treatment burden by showing greater durability than current available agents. And we have seen that data in their phase 1b trial, as you mentioned. Peter, any thoughts on KSI 301?
I mean, I think this, of the many different things that we're going to discuss, I think this has tremendous promise. You know, the idea of delivering a platform and a drug of your choice by intravitreal injection and needing treatment, you know, once or twice a year, I think has tremendous implications and tremendous promise. I very much look forward to the outcomes of the DAZZLE study.
I agree, Peter. I think it has great potential. And of course, we are waiting for the DAZZLE trial, which will show us the comparator data with the aflibercept on label. And if we can have durability, 4, 5, 6 months with this agent, obviously it's super crucial in the trials. They're designed to go up to Q20 weeks, but as you mentioned before, I think in real world we'll push the limits and see how far we can go. In the phase 1b trial, there were many patients who didn't need any treatment until mandated 6 months dosing in patients with neovascular AMD, and we also saw the durability in diabetic macular edema as well as retinal vein occlusion. So we'll see how the data pans out. Of course, the data has to speak for itself, to see how the visual acuity gains, anatomic changes, as well as durability and safety looks for KSI 301. Justus, for you, I mean, you're injecting a biopolymer in the eye that has great durability. We're going to discuss safety in the later episode, but what are your thoughts about injecting a platform, as Peter said?
Great question is, on the one hand, whether it's tolerated by every patient or whether there's some safety concern with this new biopolymer. This is one thing. And the second thing, what I think is long-term performance is important. 6 months performance is is not interesting. So for the moment, I would be reluctant to have a meeting onto that drug. If it were what it promised, it would be a great choice for the future.
I think that's an excellent point, and I think the long-term data from 1B as well as the DAZZLE trial will let us know, plus the ongoing GLEAM and GLIMMER studies in diabetic macular edema, the Beacon trial in retinal vein occlusion. I think we're going to learn a lot and hear a lot about this drug in the future. So let's now move on to Dr. Peter Kertes. He'll be talking about RGX-314 gene therapy.
I'm going to talk about RGX-314. The phase 1 and 2A trials have been completed, and they demonstrated that RGX-314 was safe in a phase 1, 2A trial for the treatment of wet AMD, and signs of efficacy were also observed. So RGX-314 is an adeno-associated vector that carries a gene that encodes for a monoclonal antibody fragment. So the protein expressed is designed to neutralize VEGF activity that, of course, is the cause and source of neovascularization. It's delivered following vitrectomy into the subretinal space, but they're exploring ways in which to deliver it through the suprachoroidal space, and hopefully we'll see that in the next study phase. So these early trials enrolled patients who required monthly injections for wet AMD. So these are recalcitrant wet AMD patients. There were 5 arms, and each arm had an escalating dose of RGX-314. An anti-VEGF agent was administered at baseline, and if a response was seen, then RGX-314 was administered, and patients were followed monthly. So RGX-314 was safe, and signs of efficacy were absorbed. We have some new data from cohorts 4 and 5. At 1.5 years follow-up, the average change from baseline in cohort 4 was +1 letter and minus 46 microns in central retinal thickness. The average change from baseline in cohort 5 was -1 letter and minus 3 microns in central retinal thickness. So you have to remember that these are not treatment-naive patients, but these are patients that had been had ongoing active therapy. So the long-term treatment burden and efficacy results from cohort 3. We have 3 years follow-up in cohort 3. They're +12 letters from baseline. They needed a mean of 2.4 injections of an anti-VEGF agents since the administration and implantation of RGX-314. And 3 out of the 6 patients, so half of the patients, didn't require any injections over that period of follow-up. The most recent treatment burden results from cohorts 4 and 5 at 1.5 years follow-up. In cohort 4, the patients needed a mean of 4.4 anti-VEGF agents since the implantation of RGX-314, and 4 of 12 patients did not need any injections after month 6. For the latter cohort, cohort 5, there are a mean of 1.7 anti-VEGF injections since RGX-314 was administered, and 8 of 11 patients did not need any injections after month 6. So what we need to watch for, there are 2 pivotal trials that are forthcoming. The first trial, Atmosphere, is currently enrolling. 2 doses of the drug will be evaluated, including the highest dose from the original trials, and will be compared to monthly ranibizumab. The potential for suprachoroidal delivery in these pivotal trials, which could remove the surgical burden and the associated risks that come with vitrectomy and subretinal injection.
Thank you, Peter, for the great summary. I think gene therapy is very exciting. It's a new space. We have a lot to learn. But as you presented the data, we now have data, 3 years down from a single delivery. And what we have seen is great efficacy in majority of the patients and the decreased treatment burden. Of course, we can't cure all the patients, but it seems like there's a good subset of patients that are essentially cured with continuous delivery of anti-VEGF. And obviously we discussed about operating room and the burden and the risk and benefits, obviously, for patients in the prior episode. But I think if we can get the suprachoroidal delivery working, which is currently being looked at in the phase 2 AVIATE trial for wet AMD and Altitude study for diabetic retinopathy, if we can make this an in-office procedure, I think it's much more meaningful for patients, and we can maybe treat a lot more patients than we would if this is just an option for the operating room. But I think, a great option for patients. Seenu, what are your thoughts on RGX-314? And does vitrectomy and delivering the drug subretinally, does that bother you? And do you think that majority of the physicians can do that?
Arshad, you took the words out of my mouth. Subretinal delivery is acceptable in orphan diseases. You take Luxturna by Spark, maybe 200 patients in the whole country have been treated, I'm guessing at that number. But in that case, subretinal delivery is acceptable because there's so few patients. In a disease like wet AMD, probably one of the leading causes of vision loss in the first world nations, Caucasian populations, it's very difficult to deal with that population of patients and take them to the OR and do subretinal delivery. I think one of the best decisions was to move to suprachoroidal delivery and explore that path of delivery. So until we have data on how that works, I still have a guarded, guarded view of this therapy until we see more data looking at suprachoroidal delivery. But subretinal delivery, I think, would be very difficult with the high volume of AMD patients we all have in our practices.
Those are great points. I think it's taking patients to the OR, and then of course the practice dynamics and the burden. And as you mentioned, Luxturna, we don't have options. And for RP65, that's the only option we have. So I think we don't have a choice. But here we're going to have options of longer acting delivery agents, but frequent or repeated injections versus a treatment here which has the potential of essentially curing 2/3 or so of patients. Obviously, we're still learning a lot because it's a new space. Justus, for you, how does that fit in if you have a patient that comes in and has responded well to ranibizumab, like was expected in this trial, and you offer them a one and done treatment 75% of the time, but it requires surgery? How do you think your patients are gonna take that in Switzerland?
Well, I think it's the next exciting way to go with gene therapy, but we are not at the end of the road. If 2/3 of the patients do respond well, that means still there is individual response, and this shows that it may be a dosing thing, it may be that fine-tuning is an option. The thing, what my fear is, or what I would expect, is that suprachoroidal will work, but it will need a higher concentration of the virus. And the question is whether this higher concentration of the virus is capable of being washed out into the system and induce the neutralization of the effect. This is some of the fear that I have. Definitely, I can say the results are promising, but the individual response rates are so large that we are again in a range where predictability is not given, and predictability for such a drug would be key for me for such an invasive treatment.
I think those are great points. I think we're still learning, just as you said. I think we're just scratching the surface. We're not at the end of the tunnel yet at all. And I think the exciting thing for me is that the long-term safety appears to be pretty good. There's no drug-related intraocular inflammation. We know subretinal space is immune privilege, so that's a good thing. But obviously, the trial has seen some pigmentary changes in the retina, especially in the higher cohorts, 4 and 5. So we're still learning about that. And that's why, in the pivotal trials, the location of the bleb has been moved more inferiorly. So even if we get pigmentary changes, we don't get any central involvement. But we're still learning a lot. And Seenu trains a lot of residents and fellows, and I'm sure Peter and Justus, both of you do. So I think it's a procedure that's not easy for the trainees to learn. And I think with practice over time, we will learn it. And obviously, we do TPA for subretinal hemorrhage, but there the retina is partially elevated. Here, you're gonna have to lift and put a bleb in an attached retina. But obviously the surgeons that were in the trial, except for me, were really, really good. But we have seen good outcomes. So I think it's a procedure that people will need to be more comfortable with. And And I think the more I do these gene therapies, we are part of the pivotal program too, and I've done many of these. I think you realize that it's not that hard, but of course, the unexpected risk, as Seenu said, of surgery, endophthalmitis, retinal tears, is always going to be there no matter what you do. Peter, any last comments from you about RGX-314 before we move on?
Yeah, I mean, I have the same reservations that Seenu and Justus have expressed, but this is really a bold new frontier. There's no question that vitrectomy and subretinal injection of gene therapy is not a trivial procedure, but imagine, I look forward to the day when we can inject VEGF neutralizing cells. Let's imagine if we could replace the RPE with RP cells that produce anti-VEGF therapy. So we alleviate the problem of geographic atrophy and fix the problem of neovascularization at the same time. I think that day is, maybe not imminent, but I think it's on the horizon. I think these are exciting, bold new therapies that I look forward to hearing more about.
Thanks, Peter. I think that's an excellent point. So now let's move on to the next treatment is ADVM-022, which is an intravitreal gene therapy. And Dr. Justus Garweg will give a quick update here.
I'm excited to present the preliminary data of the ADVM-022 and the phase 1 study, which is still ongoing. This is an intravitreal injection, which is as easy as injecting aflibercept or ranibizumab, but it's a gene therapy that has so far been shown to be safe in patients with neovascular AMD, and efficacy has also been observed. The rationale behind this, it uses a novel adeno-associated virus with a capsid which is capable of producing aflibercept and delivering that directly to the retinal cells following a single intravitreal injection. And this is what makes the thing interesting. The design of the AMD study, 30 patients were included in this study into 4 treatment groups, and all those patients formerly had a high treatment demand for anti-VEGF injections to maintain their vision. Patients were divided in a high dose and a low dose groups, and because in the early phase inflammatory responses were seen, oral steroids or corticosteroid eye drops were used to control inflammation. The outcome was assessed at week 26 and went 52, and patients were then followed until week 104. The first results indicate that the drug is well tolerated. A prophylactic steroid eye drop has been shown effective in curbing the early inflammation, which is present in almost any patient. 13 or 15 patients who were on steroid eye drops have discontinued the eye drops during their treatment. In the low dose group, there was a treatment response in 60% of patients who did not need an injection at the end of year 1, and 73 of the patients did need either 0 or 1 injection in the first year. In the high dose group, the effect was even increased with 87% of patients not needing any injection during the first year after that ADVM injection. So based on the very good responses reported here, ADVM-022 has been forwarded to a phase 3 trial, which is expected to start within the next months.
Thank you, Justus, for the great summary of ADVM-022 OPTIC trial. And of course, as you mentioned, it's an in-office intravitreal gene therapy. But on the flip side, we also know that injecting AAV, you're injecting 2E11 or 6E11, so 200 to 600 billion vectors intravitreally, obviously can cause issues with immune response and inflammation. And that's why the drops were introduced initially in cohort 1 and 2. There were 13 days of PO steroids, and what we saw was there were breakthrough inflammation. So in 3 and 4, as you presented, were topical drops for 6 weeks. But we have seen that higher dose cohort 1 and 4 have more inflammation and longer inflammation than cohort 2 and 3, and especially 3 with topical drops. And that's why, the decision has been made to not take the higher dose forward. Obviously, the pivotal trials were planned to start later this year. But then in the diabetic macular edema infinity trial, we saw a patient who had an adverse event or SUSAR or serious unexpected event. And we'll discuss that in the safety section. Seenu, your thoughts, and then Peter after that, before we move on, about intravitreal gene therapy and long-term efficacy and safety of the approach.
I want to echo Peter's, Dr. Kertes's comments with the last discussion that this is an amazing frontier. And I think Luxturna gave us a lot of excitement and enthusiasm, not just in ophthalmology, in all of medicine, that gene therapies could be a very useful way to treat patients. And going into the Adverum therapies, I was very into the Adverum trials. I was very optimistic that we had an intravitreal injection where we could deliver gene therapy, and not a subretinal injection, which was led to a lot of optimism from my standpoint. But you said it best that the inflammation concerns, which we will talk about in a later discussion, is very serious. Not only topical therapy was investigated, and then oral steroid was investigated. And despite topical and oral steroid, the trials were halted due to very severe inflammation leading to hypotony. So I'm concerned. And in terms of the trial design, I think there was under-treatment. There was a very stringent protocol for retreatment. Patients had to lose significant vision, had to have a lot of fluid on the OCT, accumulate a lot of fluid on the OCT before they could be rescued. And that obviously is not the way we practice, which also concerns me that, compared to the retreatment criteria in the CAT study, for instance, any fluid, any vision loss was a trigger for retreatment, but certainly not the case in this trial design.
Great points. Seenu, any wrap-up thoughts from you, Peter, about ADVM-022?
Yeah, I mean, I find these results very exciting. The prospect of delivering gene therapy without the risks of vitrectomy and subretinal injection certainly has tremendous appeal, but safety really has to be paramount. And it's not just concerns about intraocular inflammation, but what it takes to control that inflammation. If the treatment of the inflammation is worse than the inflammation, then really have to pause and make sure we're doing our patients a service. But I mean, all these things are bold and new, and they'll take some refining. But I think the future is very exciting and very bright.
Given the severe inflammation in a majority of cases, retreatment is definitely not an option. So the durability of the first injection will define the future of this drug, I think.
I think those are great points. I think it's one and done treatment with supplemental if we need. And to Peter's point, I think this is very exciting times. I think I'm looking forward to the next 5 or 10 years where we have better vectors and better learnings about how to manage these patients, maybe neutralizing antibodies play a role, and how to really cater the treatment so we have good efficacy and manageable safety. So with that, let's take a short break, and we'll be back with the case in a minute. Hello again, and welcome back. Now we're going to have Dr. Seenu Hariprasad present an interesting case from his clinic.
So the patient I'll be presenting is a very interesting case. As I said in a previous episode, we learned a lot during this past 15 months of COVID, and we switched a lot of patients to what we considered a more durable treatment, brolucizumab. And I want to share this experience, why we switched very early to help survive through the COVID pandemic, in terms of not knowing when we'd see these patients again, and seeing a great response by switching from aflibercept to Beovu or brolucizumab. This woman is a 59-year-old white female, and she has exudative AMD in the right eye. And she received 2 Eylea injections every 4 or 5 weeks with persistent subretinal fluid and a PED in her right eye. And brolucizumab was administered to achieve better drying, but the reality is that we were at a time when we didn't know when we would see her again, and at the time we considered brolucizumab to be more durable than aflibercept. At baseline, when she received the Beovu injection, her vision was 20/50. So at the time we switched to Beovu number 1, you can see that despite having 2 aflibercept injections on about a monthly basis, or maybe 5 weeks apart, she had a complex clinical scenario, subretinal fluid, as well as a small PED. But it's certainly not the most straightforward case. And after 5 weeks of switching to Beovu, the first injection, her vision improved to 20/40, her OCT was bone dry, and subjectively, the patient was very pleased with the improvement in vision. So you can see from the baseline visit where we switched from Beovu to Eylea, from Eylea to Beovu, look at the improvement in the foveal contour. She picked up 1 line of vision. But the story is even more interesting that she had not required an injection for 10 months of follow-up. And so it's not just that we dried the retina, we picked up a line of vision above and beyond what we achieved with Eylea. And of course, she only received 2 Eylea injections, so we didn't give Eylea the full opportunity to work. But the point is that 10 months of follow-up, she did not require an additional injection. So we believe that switching to a new generation anti-VEGF in some cases may lead to a better drying effect and increased durability. And we have to really look at adverse event profiles of these new generation therapies and take them into the context of benefits such as excellent drying effect and excellent durability.
That was an excellent case, really highlights the drying power of brolucizumab in terms of controlling the disease and great durability. So I think you managed the patient very, very well. Justus, I know you have used brolucizumab for over a year now. Have you seen drying effect as well as durability similar to what Seenu has described? Of course, each patient is different, but do you feel like it's the best drying agent that is currently approved?
It's absolutely my experience that this is not a single case, but this is the standard. The drying power of Beovu exceed that of the other 2 marketed drugs. That's no question. What is surprising here is the 10-month effect. This is something that I haven't seen in that extension. But generally speaking, the treatment duration and the treatment strengths are clearly longer. What this case indicates is very important. It does not seem to need a loading phase in the majority of cases that are switched. Even the high demanders do not need a loading phase. And this is well my experience.
I think those are excellent points. I think my experience is the same as you. I don't think we need to load patients that we are switching because the drug is so powerful. I usually bring them back at the same interval that they were before and they were dry. Then I don't re-inject. I actually monitor them every 2 to 4 weeks, more kind of like a treat and extend approach until we figure out what the sweet spot is. And just like you said, Justus, I've seen patients go anywhere from 2 to 6 to 8 weeks longer than what their previous treatment was, and their disease was well controlled. Obviously, we're going to talk about safety in our last episode. So we have to balance efficacy and safety of any new agent. Peter, does this case from Seenu excite you about brolucizumab once it's approved in Canada? Any thoughts on the case?
Yeah, I mean, it was a great case and very impressive durability. What was also impressive, I mean, we had in previous episodes, we talked about the presence of pigment epithelial detachments and how we usually don't chase resolution of the pigment epithelial detachments with our treatment, but it's always reassuring and nice to see those pigment epithelial detachments go away. I always worry about that they'll get replaced with geographic atrophy, but even though I tolerate pigment epithelial detachments, I'm always happy when I see them, if not resolve entirely, like in Seenu's case, I'm happy when I see them get smaller and shrink. I really think it really speaks to me that this drug is beneficial and working.
Those are excellent points, Peter. Obviously, because we all want to see normal anatomy. So we want to flatten those PEDs if we can, but obviously we're not chasing them if there's no intraretinal or subretinal fluid. So with that, we'll wrap up this episode. Thank you again for listening. Thank you to our esteemed international faculty for robust discussions. Next time, we'll review real-world and clinical trial safety data in wet AMD. Please also check out images from the cases that have been presented here on itube.net. Thanks again for your attention.